Good afternoon, everyone. I'm Dr. Nancy Kreider. I currently teach full-time at the UT School of Nursing, Cizik School of Nursing, in the Doctor of Nursing Practice program. I've been in nursing leadership for a number of years. I also have a doctorate in public health, which is really where I really got interested in health literacy. And I'll be presenting today with Colleen Manning, who is a doctoral student at UT. Go ahead, Colleen.
Hello, my name is Colleen Manning, and I'm a family nurse practitioner, and I work in primary care and also a doctoral student at UT Health Cizik School of Nursing. And I want to thank you all today for having us to speak about addressing barriers in health literacy within the deaf community. So let's now review our learning objectives. So today we will be going over aspects that we can identify within deaf culture that impact health literacy, as well as identifying communication and language barriers that hinder health literacy among deaf, and to name at least one communication method or technique that can be used to help improve communication with our deaf patients and deaf people. Next. So a little bit about my story and why this is personal to me. I am a CODA, which is known as a child of deaf adults. Both of my parents are deaf, and you can see them pictured here on the slide with my two daughters. And my mother, who was born deaf to hearing parents, was the only child in her family who was deaf. And for my father, he was born hearing to two deaf parents, but at the age of 2, lost his hearing due to measles. And he wears a hearing aid, but for each of them, their environment that they grew up in looked very different. And so I'll be giving examples throughout the presentation of how that not only impacted them as they grew up, as they were raised, but also how it has affected my view of how I care and provide care to deaf patients and the deaf population. Both of my parents did have a mixed education. They both attended mainstream public schools. There were no accommodations for them. This was in the 1950s, 60s. So these public schools, of course, did not have sign language interpreters like we do today. And private deaf schools back then were known as oral schools. And in these schools, they were fixated on speech. And so they were known as an oral school for the deaf, and no sign language was used or taught in those schools at that time. And so, as I mentioned, each of their upbringings was very different. And so I just wanted to at least share some of that with you all, so you kind of had an idea of where, what this means to me and where I would be coming from as I move on to discuss this further. Next. So how do we define deaf? So as you see, deaf with a capital D are individuals that self-identify with deaf culture. They have severe to profound hearing loss, either congenital or acquired, and they identify as being part and belonging to the deaf community. This community is a distinct cultural and linguistic group that uses American Sign Language to communicate, and members of the deaf community feel that their identity can be fluid. It may change over time or with setting. Deaf people would also say and make it very well known that they do not view their deafness as a disease or a disability. For them, it is a difference. You know, they are living in a world where not being able to hear is the norm, but to them, it is just a difference and not viewed as a disability. And so the deaf culture really is very much defined by both their deafness and their language, American Sign Language. And so these members share common experiences and values. Next. So when we're defining deaf versus deafness, hard of hearing individuals would have a hearing loss that can be very varied, from mild to severe. Some may wear a hearing aid and some may have cochlear implants. But these devices do not necessarily restore their hearing to normal levels, nor will they enable a deaf person to be able to hear at a normal level. Some will be able to pick up the phone and have a conversation, whereas others may only hear environmental sounds. And so not all of hard of hearing individuals are going to self-identify as being a part of the deaf community. And we want to think of our senior citizens, for example. These are adults who it's age-related hearing loss, but they would not self-identify as deaf because they do not communicate in sign language. Also, many hard of hearing individuals will communicate via spoken language. Their communication may or may not be impaired. For example, my father, who does self-identify as deaf, but also hard of hearing and wears a hearing aid, he is able to converse, and his speech is pretty well enough for most to understand him. However, his primary method of communication is American Sign Language. And so it often has led to people viewing his hearing aid and when they hear him speak as him being able to just have a conversation without the use of any accommodation. And that really does cause a lot of miscommunication, misunderstanding when that occurs. So we'll be discussing later how important it is to really make sure you're clarifying communication preferences with deaf and hard of hearing individuals. Next. So our deaf population is one of the largest identified disability subgroups in the United States. And the statistics concerning the amount of people who identify as deaf is not well captured. Across all age groups in the US, there are approximately 1 million people, so fewer than 1 in 20 Americans who are over the age of 5 are functionally deaf, and half are over the age of 65. Now, more than 90% of deaf children are born to hearing parents. And there are many reasons for why we do not have accurate statistics on the deaf population, but I want us to also discuss later in the presentation how we can focus on doing a better job, especially within healthcare, to document disability status within the electronic health record. And I'll be going into that in more detail a little later on. Next. So American Sign Language is truly what defines our deaf community. So the first American School for the Deaf was established in 1817 in Hartford, Connecticut, and it was the first free public school in the nation. And American Sign Language was born from the intermixing of deaf home sign, so signs that came from all across the US of deaf children and their peers, as well as what was being taught in the school at the time, which was influenced by French Sign Language, being that one of the founders and educators was from France. And so over time, sign language has evolved into a rich, complex, mature language, and it is what defines the deaf community. It is their native preferred language. All other languages, including English, are viewed as a secondary language. Sign language, as many have seen, is a very visual language. It involves the shape, the placement, the movement of hands, as well as facial and body expression. And as I was mentioning before, with my mother having been the only deaf person in her family, as is the case for most deaf children, she does not intimately know her biological parents or her family members because of that communication difficulty for her growing up. And so this is commonly seen in the deaf community because their needs, their interests, their cultural heritage are not known and shared by their hearing family members. And so that close-knit community often learns the majority of ASL, health information, culture from peers rather than their family. And it's often also the main source of acquiring new information and knowledge is just from their peers. Next. So American Sign Language is a distinct, separate language from English. It has its own unique rules of grammar syntax. Although ASL is predominantly used here in the US and many parts of Canada, it's not universal. So there is a different sign language, for instance, in England, where British Sign Language uses a two-handed alphabet, versus here in America, we have a one-handed alphabet. And so I've shown you the pictures here on the screen for what that looks like. There's also regional variations based on where you live in the US, similar to how we have different dialects and speed with our language based on what region we're from. That's also commonly seen in American Sign Language as well. Next. And the deaf education and literacy level that I want to really help to have everyone understand better is nowadays, American citizens, deaf American citizens, have many options for their educational background that they choose to partake. There are currently 49 residential and day schools for the deaf. These are both free, public, or private. And in 2017, based on an American community survey that was conducted nationally through the US Census Bureau, approximately 83% of deaf adults completed high school and 18% completed a bachelor's degree or more. And this is in comparison to hearing adults, where 89% completed high school and 34% a bachelor's degree. And so remembering that English is a secondary language for deaf individuals, this is also why it translates into their being limited English proficiency skills and literacy skills, despite having a high school diploma or higher. Next. So we know now that ASL is a very visual language with no written form. And for deaf and hard of hearing individuals who have this limited and lack of English proficiency with reading and writing written English, majority of them have grown up in hearing families where they've experienced something known as the dinner table syndrome. And in deaf culture, what this means is that there have been many years spent at the dinner table watching their close family member and friends conversing with one another, as they are perpetually left out of the conversations, and them not being able to understand or decipher what's being said deprives them of the incidental learning opportunities that many of us in the hearing world take for granted. And this loss of incidental learning and information marginalization, it occurs on a daily basis. It's regardless of work, their school, their friends, their family, etc. And it places our deaf patients and our deaf in a vulnerable sector of our healthcare industry. And the studies that show deaf people compared to their hearing counterparts are accessing primary care much less and utilizing the ER at higher rates are really related to the lack of communication access. And there not being enough information, health information done in sign language is also creating them scoring lower with regards to health literacy and health knowledge. And so due to these inequities, deaf people are at a higher risk for adverse health outcomes. And that's compared to the hearing world, where they've seen in studies that this relates in cardiovascular health, in testicular cancer, and pregnancy and birth. And so now I'd like to turn it over to Dr. Kreider, who will discuss more on the health equities. Oh, Dr. Kreider, there you go.
Thanks, Colleen. I turned off to say quiet on this. One of the things, this is where Colleen and I intersect. We are both living in Houston, Texas right now. And as we got to know each other, and she said her parents were deaf and they went to the American School of the Deaf, I said, I've been there. I went to University of Connecticut. I did my community and public health and pediatrics at the School of the Deaf. And it was kind of intimidating to me because it was very quiet. People were moving very fast, ha, 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 and clearly knowing what they were saying. And I was on the reverse side of what she described as the dinner table conversation, recognizing that I didn't have a clue with what they were saying and thinking that, oh my, I don't want to do something to insult them. And so when I figured this out, when she started telling, I knew health equities as a nursing administrator and leader. Of course, the American with Disabilities Act came in 1990. It was amended in 2008, but that was looking at protecting the civil rights of people and disabled. And it focused in early days a lot on voting, parking, mobility devices, and effective communication. But the effective communication came in different things that people would think hearing aids or a scribe or just the telephone. And what they did is it focused a lot on local services, business accommodations for people. And it really didn't get into much of the diagnosis and health treatment until around, when you think of some of you are old enough to know this, about 1995, we got in from the Office of Minority Health, culturally and linguistically appropriate services standards in there. And those really started looking at how minorities and those with disabilities, particularly hearing and vision, really had poorer health outcomes because they had lower education and they were really in what was called the low English proficiency. And that's when we started looking at what was really culturally and linguistically driving these health inequities and the disparities we were seeing in health. So they responded more in the line of how do we deal with health inequities? So according to the Individuals Institute of Medicine, we were looking at the prescription to end confusion. We were also introduced to, probably around 2000, the culturally linguistically standards, as well as some guidelines to cultural competency. And we all went through that. And I was still a nursing and leadership and administrator then. So we were looking at how do we make sure this happens in acute care settings? And we understood interpreters and ACL. But now as it gets to more of the Affordable Care Act come in, and they really beefed up cultural competency and strengthened the laws. So let me go on to the next. So here we're seeing a multitude of barriers to getting care. You get to a doctor's office and no one knows how to sign. You have to fill out a very high level reading document and you don't know the words, and neither does the child who often gets in. So we started getting standards out there. So the literacy barriers really got in ineffective communication. And when you say lost in translation, quite honestly, until I met Carlene, some of it I had never really found the nuances like we do. I knew about it with foreign languages because in Houston, we have a large minority population, and working for the public health, the public hospital in Harris County, fourth largest in the country, we had many, many minorities. So we were translating into Chinese, Vietnamese, Spanish, English, Russian, many, many ones there, but not effectively doing it with the deaf. And while we had some ACLS interpreters in healthcare, they were not trained healthcare interpreters. So that gave us a little more nuances about what do we really need to do with communicating with deaf people when they're in primary care, more long-term care, and particularly medical procedures that Colleen's going to talk about here a little bit more. So you'll see this low literacy status really is driven by a host of factors, and it's really down to that communication and language barrier piece. There's socio-demographic factors. Those we kind of all know about these days. They're much more public, and they're much ones where we're taking action steps. Now, when you look at media, radio, or in back with the ADA again, this is where people were left out, because you'll say they'll be talking and it's clear they don't understand. It was like, oh, well, it doesn't matter anyway. And that's kind of like you gave the impression that it didn't matter that you were deaf, you weren't important enough to know and really try to understand. The lack of this education and standardization, particularly among deaf people, was really noticeable, because I didn't realize till later that all deaf people didn't go to a school for the deaf that taught sign language. I knew about oral schools, and I'm not sure what I thought, but they taught verbally speaking. And in the 50s, 60s, 70s, before ADA, that was really where they were, that the population was asked to accommodate to the majority, like many things happen. And yet we didn't know how to accommodate in reverse. So family and friends then, when they've got non-fluent, people started to learn more about how to address these. And they really started looking at what kind of technology and other things were out there. The American with Disability Act, I told you, provides protection from discrimination based as it relates to employment and public-private. So again, this was buildings, sidewalks, transportation, local government, how to vote, how to even go to a meeting or look at, when they didn't have an interpreter there, they didn't have an interpreter for crisis intervention until recently on TVs in different places, that they might not have someone with the ability to sign. The person is with a disability is, as you know, anyone with a physical or mental impairment that substantially limits one or major activities, including hearing and vision. But we didn't have a lot going on for hearing and vision, except scribes and readers. And again, you didn't have words. So I want to turn, we've got ADA now provides aids and services with the goal that communication with people with disabilities, the words here are clear, is equally effective as communication with people without disabilities. That was not in the ADA. We've got a lot of that in the ADA about schools, and they have to provide early childhood interventions, and they have to provide them at schools up until they're 18. But beyond that, it does not say they have to, this word, equally effective. But now it includes providing auxiliary aids and services with people who are deaf or hard of hearing when needed or upon request. It's also the onus on us in healthcare and in the community to be able to find out what is their needs. Based with the class standards, it's looking not just on who has needs, but how do I communicate with that individual person to meet their individual needs. And the type of these auxiliary aids and services really depends on what situation the individuals find themselves in, what's being done. And with healthcare, as we know, we have to do a lot of the education for self-care and follow-up care, and bring it down to 4th to 6th grade level to be able to speak. So with the deaf people population, we need to do the same things. With that, I'm going to switch it back to, by the way, this sign up here, this is the universal sign that says there's some hearing accommodations going on. And we've put these through. The next sign you're going to see, we've got the ADA now includes aids and services for the deaf. You'll see some of these international signs. Some are better than others for people to recognize, but it calls for qualified sign language interpreters, real-time captioning, written materials going on, and they use a variety of telecommunication technologies, which has really made this just skyrocket in possibilities. And Carlene's going to talk to you a little more about video phones, caption telephones, open captioning, closed captioning, assisted listening devices, and that. So let me turn it back over to you now, Colleen, and you can go on and tell us about the nuances of some of the real-time technology.
Thank you. So if we can go back one slide real quick, Dr. Kreider, just mentioning to everyone that the examples of the most common aids or services that a deaf person is going to request are going to be sign language interpreters, of course. Real-time captioning, very briefly, is actually a function that could be used right now as we're presenting. There's an option to turn on captioning, and that uses AI technology to translate my voice into text. Of course, the technology is not perfect, but it is something that thankfully we now have that we didn't have, years ago, so that deaf people, when they're in class or lectures, can actually use that technology. Also, telecommunication technologies, as Dr. Kreider said, has skyrocketed. The archaic way of communicating when my parents were when I was growing up and I was much younger was the TTY. And then when the internet evolved, and then all of what we have now with the smartphone technology, it has truly taken off so that deaf people are more autonomous. They are able to now place and receive calls themselves without the assistance of just technology that is slower and not able to be up to speed with what they need and what they want. So of course, qualified sign language interpreters are going to be the primary type of aid or service that your deaf patient or person will request to have. And with regard to a little bit about captioning, for those who may not be aware, open captioning is something that's always in view, it's fixed, but closed captioning has options to be turned on or off. So I'll go ahead and move on now to discuss a little further on the next slide about how the electronic health record could maybe help us in improving accommodations for our deaf community. So I wanted to briefly talk about the Disability Equity Collaborative is an organization that works to provide evidence-based knowledge and practical solutions and tools to address complex problems in disability access in healthcare. I am part of one of their work groups called the Documentation Work Group, where we're seeking to develop standards for documenting a patient's disability status in the electronic health record. And the reason why this is so important is because without addressing and having a way to document disability status, how will we be able to then make the appropriate accommodations and provide those services? So what's really interesting, and I look forward to seeing, is that later in the fall, when the national study rolls out across 8 primary care clinics in the US that are all using the same EHR system, they will be implementing documentation disability status standards and how that is helping to benefit the provision of disability accommodations. So something to maybe ask yourself and to look at where you work would be, how does your workplace assess and assist for accommodations currently for deaf people? And a lot of times this has to utilize technology, which is always a work in progress, but it is something that we will be seeing more and more about as we go forward in the future. Next. So the sign language interpreter, they are specialized with training and credentials and have developed the skills and expertise needed to mediate meaning across language and culture. To ensure that you've hired a qualified interpreter, you want to make sure that the certified interpreter is a professional that has passed a state or national level of certification. They're bound by a strict code of professional conduct. This is established by the IRD, Registry of Interpreters for the Deaf. And I've left their website, rid.org, with a phone number here so that you can save that if you'd like, for being able to locate and have the ability to search for qualified interpreters who are certified. Many times your workplace may already have either an agency or a service provider they're using. And if you don't have one, or you ask and there is not one, it is really important to try to look for that now, because when the need arises, it can be very difficult to find someone on a short notice. Many of these sign language interpreters are employed by local agencies, or a lot of them just work remotely from home and they're contracted with service provider companies. Next. So let's discuss, which historically we know this happens a lot, but let's discuss why using accompanying adults and children is really not acceptable. So the ADA places the responsibility for providing effective communication, including an interpreter, directly on covered entities. You know, we cannot require a deaf person to bring someone for them to interpret. When it is covered, when a covered entity rather is able to rely on a companion to interpret, is typically in these 2 situations, and this is directly from ADA: in emergency or in non-emergent situations where there is criteria that needs to be met. The individual, so the deaf person, should be requesting this. Also, the accompanying adult should agree. And there is a reliance on the accompanying adult to have that is appropriate given the circumstance. So for instance, you know, it would be inappropriate to rely on a companion to interpret who is feeling conflicted about communicating maybe bad news, or maybe has a personal stake in the outcome of a situation. And of course, as we move on to the next slide, please, it's very, very common to see, not just in the deaf world, but also in any environment where an interpreter is needed for a non, English speaking person, this applies. And so, we know children lack the specialized vocabulary needed to interpret effectively and accurately. There is a lack of impartiality, impropriety, and also the discomfort with personal issues. Also, adults and their children don't have a medical understanding if they're not directly in that field. And the stress that it puts on those relationships can be tremendous. Also, HIPAA and privacy laws, if the patient is not giving their consent to use that family member or that accompanying person, it directly does violate that, speaking about things that are related to their care in front of somebody else. So bottom line is really to not request that the deaf person bring someone with them unless it's being requested by that deaf person and all parties that are involved are comfortable with that. Next. So the telecommunication services that we have available when we're talking with our deaf patients. So the national free nationwide TRS is by dialing 711. This can be dialed from us, a hearing person, or from a deaf person. And it uses communication assistants who are serving as the intermediary between the deaf person who might be using a text telephone or a TTY and those who are on the voice telephone. And the more commonly seen form of telecommunication now is the video relay service. This is the one that most of us are familiar with when a deaf person is placing a call and you hear on the other end a operator or a communication assistant saying, I have a deaf person calling in right now who is using their video phone to speak to you. And so that subscriber would be the deaf person who then, in using their internet service, is placing that phone call or receiving it from maybe your office or where you work. And the relay operator is able to communicate and act as the intermediary. So many deaf people use the video relay service. I'll show you here on the next slide an example of actually how this is used. So what I'll do is I'll go ahead and share my screen so I can show for everyone a brief video. Thank you. Let me make sure that everybody can hear the sound. And all right, I'm going to go ahead and show you this brief video of what it looks like when a person is placing a video relay call.
Please continue to hold for the next available video interpreter. Thank you.
So that interpreter is now showing them the phone is ringing.
Hey, Shannon, what's up?
Hi, Dylan. How are you?
Okay. Let me go ahead now and get back to our presentation. Oh, Dr. Kreider, if you could, please. I just want to make sure that it's back up. Thank you. So that example there of just using a video relay service will also allow that use on the go. So many of our deaf patients will have on their phone an app they're using to be able to place and receive calls when they're not home. So that is something that you will commonly see. A deaf person may even provide to you or your office a video relay number, and that number is their direct line where you would reach an interpreter immediately, and then that person would then help set up the call for you. Next. So now I'd like to talk about video remote interpreting. So this is also a type of service that we are seeing it's a fee service, of course, so not free or subscriber based like the video relay service, but this is allowing our deaf individuals to communicate to hearing people through a live video conferencing. So this is what we're seeing now happening in a wide variety of settings: the hospitals, outpatient clinics, mental health, police stations, legal sectors, schools and universities, etc. And if you choose to use a VRI service, there are performance standards that must be met, and you can find that information on the ADA website. But there is also a concern on the part of deaf people for for VRI services being used primarily in the setting of hospitals, especially. So I'd like to show now the next video of just briefly what a video remote interpreting service would look like. So I'll go ahead and share my screen again. And let me just bring up the other window. Thank you.
Sign language, or ASL. Did you know that sign language interpreting services can also be provided remotely? This can be helpful when an in-person or community-based interpreter cannot be found locally, or when interpreting is needed for an online meeting or training. When using video remote interpreting, or VRI, the room is arranged so the person who is deaf can easily see a video screen that is connected to an interpreter via the internet. It is important that the interpreter be able to hear everyone who is participating in the meeting.
All right, I'll stop right there. And then I'll have Dr. Kreider pull back up our slides. But that video there is an excellent way to be able to show, and this is being used, as I said, all across the healthcare setting, but it's really a type of entity that contracts out. So hospitals will have typically a VRI service provider where they either have paid for service on demand or maybe are using by appointment, especially if they may not have, if it's a small practice or maybe a small setting where they don't have as many interactions with the deaf community. Next slide, please. So I'd like to talk about why right now in the deaf world, VRI is facing a lot of challenges and controversy. So since VRI has just exploded within the healthcare setting, it is often being used as the sole auxiliary aid option. And this is due to it's a low cost for the entity, and it's a convenient way to pull up an interpreter very quickly. However, the deaf community is concerned about the over-reliance on this type of newer technology and their lack of involvement in deciding how to best provide the service. In 2019, a study from Kushner and others found that only 41% out of 555 VRI users in the US were satisfied with the quality of service used in the healthcare setting. And the issues that I'm hearing from deaf patients that I interact with, or from just the deaf community that I'm a part of, is that it's being chosen for them as the way to have an interpretation done and not with them. And so when they are going to their appointment or when they are in a procedure, they're just as shocked to see that a video remote interpreter has been arranged and not an in-person interpreter that might be more suitable for that setting. If I could briefly just mention that I had recently at one of my patient encounters, my deaf patient went to her specialist. She was going to be getting information about a colonoscopy, and she had been there before. They had arranged for in-person interpreters when they had seen her in the past. This time she was shocked because when she was brought back to the room, the staff member had brought up on her phone a video remote interpreting service that they used. And so she felt, okay, this is all right. You know, I'm not necessarily having a procedure today, so we'll go with this. But when the interpreter came up, she clearly was in a car, and the video was extremely just jarring as the person in the car was driving. The interpreter said, "Oh, don't worry, I'm not driving. It's my husband who's driving, but I can help you and I'll provide service to you." And she immediately felt very uncomfortable, and she had stopped the visit. And, she had to advocate on behalf of herself. And she let the staff know that I'm not comfortable now having a conversation with my doctor or you when my interpreter is in a car with her husband who should not be listening to this conversation. And also the video is very hard for me to see her. I can't actually see her full upper body. So I can't understand what she's really saying. And so she had chosen to reschedule her appointment. But I thought that was a really good example to bring up at this time during this presentation, because these are some of the things that the deaf community is very frustrated by. And so, of course, when we're talking about securing an interpreter and the need might happen very quickly, we want to do everything we can to have available agencies we use so that when a certain situation would call for an in-person interpreter, we can arrange for that. We know where to go, versus if it is going to be maybe just a straightforward type of a setting where you can video remote interpreting would be very suitable. Next slide, please. So now let's discuss closing the health literacy gap. It really starts with communication. So ask your deaf, hard of hearing patients for their communication preference and list those in the electronic health record for all to see. Of course, having access to an ASL interpreting service, whether it's in-person interpreters or a video remote service, and to be respectful of deaf culture and values. The visual access is so key with this population. Facing them and maintaining good eye contact, as well as avoiding obscuring your face, are going to help that person to understand when you speak with them. And optimal visual-based information is going to help address health literacy gaps, because they do find that when they see information in pictures presented to them, they already have such a visual understanding of their own language that being able to see how to appropriately take care of, let's say, a wound, and having steps drawn out visually for them or given to them will serve much better than just having a conversation. Next slide, please. So now we're going to discuss how, of course, to provide really good, effective communication techniques. And this is for all of our patients who require interpreters, not just our deaf patients. Having your ID badge clearly displayed, reducing the background noise so that the patient who might be hard of hearing and uses a hearing aid isn't having all of that extra noise causing more of a disruption. Well-lit room, minimizing a visual distraction, so not really having maybe a monitor going with a video or TV on while talking to them, and speaking at a very moderate pace. The interpreter is going to try to keep up with what you're saying, whether it's remote or in person. So if you're going too quickly, things could get lost in translation. And avoid exaggerating your words. This is really crucial for lip readers, so not just for our deaf patients, but our seniors who might lip read. And if your patient looks confused or they're telling you that they don't understand, avoid repeating the same words and try to rephrase so that you can get better clarity from the patient on whether or not they understood you. And inform when you change a topic, because I will find myself when I've talked with my deaf patients, even if I sign and move too quickly, I've already moved on to maybe like talking about their blood pressure, but they're still hung up on the fact that we were just discussing their diabetes. And so an interpreter has the same issue. If you're going right into another topic without really having that without mentioning that you're changing the topic, it could come off a bit confusing to that deaf patient. Next slide, please. So of course, given that we've gone through the pandemic, I thought it was very important to mention the impact of masks on the deaf and hard of hearing community. So masks have been, of course, a major communication barrier. Because ASL is so visual, facial expressions are crucial because they convey meaning in that language. And so lip readers are also going to be severely impacted by the use of a mask. So we know that it's unavoidable in surgical settings, procedural settings, but I would always ask to have staff members who were caring for my parents to keep their masks off in areas where it wasn't necessary. And that way, effective communication is clear and can take place until the point when that mask needs to now be worn. And of course, we know that the mask mandates over the pandemic were vital in preventing the spread of the virus, but it did leave some of our most vulnerable communities even more isolated. I had many encounters over the pandemic with my deaf patients where they felt disconnected from society. It had negative impacts on their well-being. And so it's getting better now for them, for all of us. But as a practitioner, and recognizing that being that I'm a CODA and I'm part of that world, I found that the best thing for me to do was to always keep sick visits virtual. And when it was a non-sick concern, we would sit 6 feet apart. I would take my mask off and we would just try to follow the guidelines that we knew could help protect both of us. Next. So visual aids and handouts. So because we know sign language is such a visual language, using diagrams, models, illustrations, this will all assist in communication and understanding. Educational handouts or resources should be in plain language around the 4th to 6th grade reading level when we're talking about our deaf patients, but also per NIH, we know that writing that is clear and to the point helps to improve communication and takes less time to read and understand. So when we use plain language, we avoid creating barriers that set us apart from the people that we're trying to communicate with. So it's something really that we should be doing, of course, to benefit all of our patients. And I've left this link here because this website through Medline Plus has material, health education material that's designed to be clear, and it follows best practices in health literacy. Next slide. All right, so this is one of my favorites that I wanted to show everyone. So here is how we can get lost in translation. So this is a picture of a FACES pain rating scale. Many people who are healthcare know what this means. However, for a deaf person, these facial expressions are actually components of American Sign Language that mean, from left to right, happy, glad, sad, happy, glad, surprise, depressed, sad, and cry. And so this just really points out the linguistic differences of the English language versus American Sign Language, because a deaf person could look at this and think you're asking them how to rate their emotional health or their emotional well-being right now. Not necessarily that it's a pain scale unless you were to review that with them and explain what it is. So this is just really to really deliver the point that it is so crucial to make sure that when we are translating and showing them material, that we understand that visual aids can have different meanings because sign language is such a visual language and has its own meaning. Next slide, please. So teach-back strategies are also extremely helpful. I know many of us in the health literacy world know about this. It's research-based health literacy interventions that promote adherence, quality, patient safety. And it's a way to ensure that we explain the information clear. We can ask our patient to explain to us what did they understand or what do they now know what we're asking them to do, and a way to even double check accuracy of interpretation. It helps to encourage questions. And so by confirming understanding, we know now if we need to re-explain if needed, and it's a way for us to check back again. Next slide. So in summary, communicating with deaf individuals is not a one-size-fits-all approach, and there is no typical deaf person. Each deaf and hard of hearing individual is unique, and they come with their own set of communication needs, preferences, and the type of communication should really be based on the setting and the purpose of that interaction. And so please determine the best way to communicate effectively with that deaf individual, not for that deaf individual. And of course, all providers should be aware that we are responsible for the accommodations that they will request. And this includes the cost of those accommodations. And it's a way to ensure effective communication, and it benefits all of us when we know that the message we are delivering is being received as it was intended. And so here on the next slide are some helpful websites I'd like to share. We can leave this up for all of you to take a screenshot if you'd like. They do have links that can take you directly to various video relay service providers. There's also some more information about the National Registry of Interpreters. The National Association of the Deaf has a plethora of resources there. And of course, the ADA, which does list on their website what performance standards need to be in place for video remote interpreting. Next slide, please. Our references, and we'll go ahead and now move on to questions, please. And thank you everyone today for your time. We really do appreciate being able to discuss this topic and how we can help to ensure that our deaf patients are able to have communication that really truly will meet their needs so that they can understand and participate and be good advocates of their own care. All right, I see down here in the chat.
I apologize, Colleen. I have to get to the questions with our moderator. So I'm gonna put you
Sure.
in a different screen set, if you don't mind.
Sure. And I'm not seeing any questions right now that are in the actual moderator favorite tab. So I think we're okay to, oh, I believe, okay, great. I do now see it as I refreshed. I'm sorry about that, everyone. So I have a question here that are there strategies for communicating in plain language ASL? That's an excellent question. I suggest that using the majority of our plain language health literacy recommendations are used as you speak, because ASL interpreters, although we know sign language is not a word for word direct interpretation of the English language, as long as we speak in plain language and use simple grammar, we are able to ensure that the interpreter, and it will help our interpreters to be able to relay to the patient that information more clearly for them to understand. But for there to be an actual guideline or recommendation on plain language ASL, no, there is not. So it's really just utilizing the recommendations that we have through either NIH or AHRQ that does discuss and has toolkits for how to put things into plain language. And then I also see here on a question, I'm starting to work with non-English speaking immigrant older adults who have a hearing impairment due to aging. Any suggestions when working with the population, as they are not necessarily knowledgeable about ASL? That is an interesting one, because that would be, so because they are, I guess, based on the language preference that they have, because they are immigrants to, and they are not English speaking, and we know ASL is not universal, it would be probably best to just directly ask those patients if they are willing to learn American Sign Language, which then would still be incorporating English as a second language for them. And there are going to be typically there are going to be many local resource groups in your community that hold ASL seminars, or through the Department of Health. They typically will have online a way to find in your city who the local organization or chapter is that does provide ASL services to those who have hearing impairments. But I know this one is going to be a bit more difficult, not that it can't be something that we can try to help assist them with in finding out ways that they could learn American Sign Language, but it would be in English.
This is where you would also go into your traditional foreign language and your plain language. I had a lot of this with Spanish, and we have Spanglish going on. So the medical error with the once, one, meaning we think of it, once means 11 in Spanish. And we had the well-educated man describe it and take 11 instead of once a day. That was really, really scary. And that's when I got into this. So I would say this is your foreign language. You use the dominant ear, you use the written and visual materials, and really get the quiet room, the direct face, because most of these people have started to read lips, but they would need to be in their primary language.
Right. I do see another question about how to use TeachBack with interpreters, and are there issues that make this harder with American Sign Language, or suggestions to make it more effective? I find, and I've seen this actually when I've been present with my parents during their encounters with an interpreter, that just simply the interpreter saying, do you have any questions? And they are following the lead of the healthcare provider. But when that provider says, do you understand? The interpreter then allows that time for the patient to then tell them what they understood from that conversation. And then if they had questions, it is a great way for them to feel that they are now encouraged to ask their questions. So really what I've seen is that it's on the provider or the person who is trying to communicate with a deaf person to say, do you understand everything now? Or is there anything I can clarify for you? And can you now relay back to me through the interpreter what you understood about what I've asked or what I've described? And then one of our participants said there's a device called Pocket Talker that can help to amplify the sound as you're talking and using the interpreter. I have heard about this. I haven't had to use it with a patient yet, but I've heard about that as well. So thank you for mentioning that. And many of you probably are aware that there are a multitude of apps that you can just download that do speech to text. And although
Right.
this all relies on the AI technology that we currently have, it's constantly being improved. So it's a work in progress, those apps, of course, but it is better than nothing. So another person said, as a healthcare provider and child of someone who's hard of hearing, would it be beneficial for the front staff to have very basic ASL understanding and communication, as well as other options for patients within the community? It's great for patient visits once in the room, but what about at the front desk or for people passing by? Yes, this is something that where I work in my primary care setting, I have made sure to create alerts on our electronic health record that identify to all of our staff, so the front desk and the medical assistant and the biller, that this is a person who communicates using American Sign Language and requires to be seen with me or to have an interpreter present or a video remote interpreter present. And typically on that alert box, I'll make sure to put there, please communicate to this patient either through writing or to allow for a voice to text app. And so we have that in our office. And so many of our staff have done that when maybe I'm not physically available or able to be present. But it is, I find deaf patients, they do feel frustrated that if they're coming multiple times to the same place and everyone's looking at them thinking that, they can hear, they constantly feel they have to advocate for themselves and say over and over, but I'm deaf, I can't hear, could you please put that somewhere so that the staff know this, and they know that when they call me back, they have to come and, greet me in the waiting room and let me know that it's time for my visit. So
one of the things is having that universal placard, that blue ear I showed you in ADA, that you have somebody there. Some of it, I would say, yes, learn some basic sign language, like, help. Or when I did this at the end, what Colleen was saying is, this means, do you understand? Because it's like to your head. So learning, and if they know that you have some basic ones, or even, again, some of the pictures I've seen people use that, but the facial and the trying, it's like any other language, they'll help you get it. So there's a lot of mining. There is another sign language that's kind of a touch sign that most people don't use, but it's kind of how you teach a kid, okay, let me show you how to do this. And, you say, Nancy, me, something like that. So those do work. But I would do a few basic signs like help, and like, do you understand? Or that to show how to wait, and changing the topics, because that would be good. Having it in the closed caption and having the reading material in that 4th to 6th grade reading level in English is really helpful for people, whether they're deaf or not deaf, because that's about the language they get to. A language level with low English proficiency. So other things like that. I see we are close to the hour. It's 3:59 here. So are there any other questions in there? It's been a pleasure talking to you this afternoon.
Yes, thank you everybody for your time. And I'm happy to, if there's any questions that are still unanswered, to go ahead and I know our moderator will help to share my contact information so I can help get you those answers as well. But thank you so much. It truly is a pleasure to talk about something that's very near and dear to my heart. And I hope to continue after I complete my doctoral studies to advocate and do more work in the community to better help our deaf community, and to take that to a national level so that we can really help improve all of our deaf community members. So thank you so much.
Thank you for your time.